Okay, so what I will do a quick introduction just to catch our breath because we were in a great meeting and discussions, and now we are changing to this open seminar. Yeah. So just to understand, we are really fortunate today, yeah, to have this delegation from the Doctors Without Borders. Yeah, we have 4 people. Yeah, 2 of them are here. The other ones, they probably just going to the bathroom and will come back. Yeah. And especially yeah, Dr. Yeah, Amrish, yeah, which is one of the directors of the Doctor Without Borders, yeah, based in Brussels, yeah. And he's also the director of a unit called the Luxor unit that do a lot of the science and innovation part of the Doctor Without Borders, yeah. So our team is quite biased because we are big fans of the MSF, yeah, and we normally take almost every opportunity that we can to engage with them to develop some ideas together, yeah. Why that is because we think that we share a lot of similar philosophies of trying to not only do good for the world, yeah, but to take some of the research to the most needed people in the world, yeah, in a way that we are also quite independent from the funders. Yeah, so many people will know me that we tell our funders that they can fund us, but they cannot tell us what to do. Yeah, otherwise we start going the direction that the funder want you to do, and we find very important that we can control the way that we do things. Yeah, and that's why, for example, in CERI we invest, and CRISP we invest so much in capacity building. We had groups and funders telling us that we shouldn't be doing that. We should be writing science and nature papers. Yeah. And we find that so important to give back to the community. Yeah. So, well, and so we are discussing some ideas on how to work together on diagnostic innovation. Yeah, how to take some of the molecular work that we do to the fields. We are talking a lot about the big pathogens that affect Africa, like HIV, TB, malaria. All of them have a big problem of antimicrobial resistance. Yeah, and how to do that, but also how to work sometimes to respond to new outbreaks, especially because the doctors from the Doctors Without Borders may be the first ones on the field and in place that no one wants to go. They love like to make surgeries when bullets are flying. Yeah, is that true or not really? Not at the moment. That's quite sensitive. Yeah, we have many conflict regions. Yeah, and how to work together to, for example, to identify new pathogens when you have an outbreak of unknown fevers. Yeah, or how to work on some of the pathogens that worry a lot us at CERI, such as climate amplified diseases, which have been neglected in Africa, like dengue, chikungunya, yellow fever, Rift Valley, which some of them even have pandemic potential. So I just give a long introduction to let you catch your breath, and it is a great pleasure to have this presentation today. What is going to be talk about epidemiology in humanitarian medical operation. And I was reading some of the comments on social media and LinkedIn that you did a fantastic presentation in Cape Town last week. Yeah, on the International Epidemiology Conference that really got people very motivated and passionate about going to the field. So that's what we have to show you today. So thank you so much for coming all the way.
Thanks, Tulio, for the very nice introductions and for having us. Yeah, so in part, we kind of wanted to give you a bit of background of like, the type of work we do, which always creates a mutual understanding. And the reason for us to be here today is also to understand the amazing work that you're doing here across the continent. And I think it also inspires a new generation of scientists, to say so. Let me see. That's it. Yeah. Yeah, perfect. With some delay. So I'm going to set the stage a little bit to explain what type of organization we are beyond the sometimes reputation that we have, and a bit of the history of where MSF comes from. So we're an organization that delivers medical aid where it's most needed, or actually where resources are often most absent. And as Tuli also mentioned, we do that in an independent, neutral, and impartial way when it comes to healthcare delivery. At the same time, MSF is an organization that wants and will speak on the medical data and the things we witness. And we do think that is kind of one of our fundamental responsibilities when you deliver medical care. Especially this time and age, not always easy with a polarized landscape and even medical care becoming more politicalized, of course. So originally founded in 1971, kind of at one point split off from the Red Cross, to say so, founded by a smaller group, and then 300 volunteers, including doctors and journalists, work together. Well, if you look at today, we actually, the number here is at 60,000, but we're almost close to 70,000 people working globally in the MSF movement of 169 nationalities. And we take great pride that we are funded in a way that allows us to bring most of our funding actually to our medical operations, but it also allows us to be flexible. And I think that is the great strength, and at the same time, the great responsibility of an organization such as MSF, that we can be the first movers. We don't need to wait for earmarked funding to finally come in. So, we do count on the generous support of more than 7 million individual donors worldwide. 97% of our funds come from private donations, allowing us to act fast. But we're also sometimes very critical where that funding comes from, because we did take government funding, for example, from different EU angles. But at the time of the migration deal in 2016, MSF decided not to take these funds, which are, of course, always the risk balance and heavy discussions you have within an organization. But in the end, making the statement of what was happening on basic humanitarian law being broken was much more important than those funds. Now, if you look at MSF at our different medical projects, what you see here is not all our projects, but including our European offices. And you can see that we're quite actively worldwide, but most of our medical operations are indeed based on the African continent, which would not surprise, I think, at this stage, many people. But also more and more, we do see operations needing to expand to different corridors of the world, not only because the number of emergencies are slowly, maybe faster than slowly increasing, but also more and more we have the capacity to detect things. And I'm not just talking about infectious disease outbreaks, I'm also talking about large migration flows that remain invisible to the eye of like the big news outlets, but do become more visible as we continue our work, but also communicate with local NGOs and other partners. Now, a very brief word cloud of the types of areas that we're working in. Yes, infectious disease is very heavy, but we also have specific looks at people that are higher at risk typically. And when it comes to, pediatric care, SRH, and also increasingly non-communicable diseases, which is something that the South African Medical Unit, of which our colleagues are in the room, focuses on as well. But it's also very much about those classical diseases. After each and every pandemic or big health event, you see the large focus on disease X. How do we get prepared for the next pandemic? But in the meantime, the majority of mortality and morbidity is caused by diseases that we know well, and that we very often have the toolboxes filled already for in terms of combating these diseases. As I mentioned, if you look at the changing trends in humanitarian response, is that we are faced with more fragile and conflict-affected areas. They're growing faster, increasingly due to climate change playing a role in there. I'm not claiming that any of us at MSF are climate scientists, but we definitely see the impact of changing weather patterns across a range of countries and regions worldwide. Much of it became amplified during the ongoing pandemic, specifically when you look at vaccine gaps. We see outbreaks nowadays more and more of diphtheria, measles, the classical ones, as I said. We also see that more people are being displaced by conflict. Forced displacement is increasing, and typically, people in migration streams, they are invisible. And in many ways, they're invisible because there is an endpoint, which is a hospital or a health clinic where we see patients, but people on the move don't stay at one place for very long. Also, the duration of responses is longer than it typically was. So we never see any more or not too often, a typical endpoint to a response or operations we have in country. However, financial support and attention is not growing accordingly, and the responses are more complex because of the politicalization, I think, of medical aid and humanitarian aid, which is very much in full blow in different emergencies at the moment. And we're not sure on how to deal with all of that. So in general, our capacity to respond to emergencies, to assist those affected, is radically tested. Like I said, focusing more on the classical enemies, neglected tropical diseases, snake bites, malaria, fish-oil leishmaniasis. We see an increase in vaccine-preventable diseases for which we have good tools in the toolbox, but they just don't make it to the patients that need them and the populations where preventive care can be implemented. We see a slight increase, or at least a stagnating trend in decreases in TB, malaria, for example, increasing risks around resistance and spreading patterns of resistance, but also increasing spread intensity due to other factors. For example, new vector species that made their introduction, and currently we see an unprecedented amount of huge outbreaks of malaria around Ethiopia and surrounding countries. Last year, we saw a record number of outbreaks on cholera. That remains definitely one of the diseases that we see routinely in conflict-affected areas or areas where you see regular floods. But also non-communicable diseases are becoming increasingly an issue because it's just simply more on the radar. But also the fact is that we intervene in areas where you have populations that typically are more wealthy, or where you see the type of patterns of diseases more prevalent. In our day-to-day, there's tough dilemmas, right? And I think it goes for all of us. But yeah, you have a lot of gray between the idea of just delivering medical care and treating patients, but you have to balance it between elements of safety, access, the impact we can have given the resources, how ethical interventions are, or the lack of interventions are. But it also includes very basic elements of who we are as humans, elements of morality. And on top of that, there is legislation, both national and international laws that we've all agreed to in times of peace or after big conflicts, but we're not adhering to. And then within that, we also have to deal with different political ways. Political leadership does really make a difference in how we can do our job. Our own human fallibility, we're not perfect. We have personal interests to think about it as well. But also, I think very much how we sometimes underestimate the right leadership. And before I was working with MSF, I was working in the health emergencies of the department of WHO, also coordinating responses. And it was always quite clear how right leadership, or the maybe not so right leadership, can bend a whole unit or department to the left or right side. So with WHO, we've also, with Gorn, came up with these trainings to kind of train people in how to do leadership, because we're trained as medical professionals or biomedical professionals, but nobody teaches us when we come in positions of leadership, how do you lead? How do you inspire? And it is really important because it determines much of the outcomes in our day-to-day work. Francesco Checchi and colleagues wrote quite an interesting paper, and then I just put these papers here so that I hope that you kind of read them, because I do think we often focus on the medical tools and the medical innovations, but here we describe case studies of large conflicts as a case study in terms of where he concluded that it was more political will that was the issue than actually the lack of evidence, even medical evidence. And very recently, when you look at Gaza, that was, I think, last week or 2 weeks ago, this opinion paper was written in the Lancet Correspondence that also kind of, emphasizes this. And I don't think it's a surprise to any of us. I just think we just don't talk enough about it because it kind of goes to the back drawer. But this is increasingly becoming a problem on how much attention goes to an emergency, and even the space we get to let medical data speak. Because even medical data, which should be neutral, I think in many ways, is politicalized in this arena. Now, speaking a little bit about my discipline, so I was trained as an infectious disease epidemiologist, and then I also did public health microbiology, so I know how to hold a pipette, and I know how to do dilutions, although I think everything is nowadays automated, so I become completely redundant. But even in the when we speak about epidemiologists, and obviously these are some slides that I used last week at the World Epidemiology Conference, there's many different epidemiologists. And I always say this because different people with different backgrounds also make a difference in like how you observe a problem or how you try to look at a problem. And one of the things, and sorry if I forgot you, if there are epidemiologists in the room and I didn't name your discipline, but one of the groups of epidemiology we work with mostly and that we employ within MSF are field epidemiologists. These are people that have followed the training and have a good understanding of, like, how do you bring these different, well, first, how do you ask the right questions? What indicators do we need? What sources can we obtain this information from? And these are programs that are quite old, but I always talk about them because not enough people talk about them. And often I get the question when I go to research institutes, like, how can I come and work for MSF as an epidemiologist? And I always say, well, these type of programs kind of prepare you a little bit more for what we call boots in the mud kind of work, so the more operational type of work. And most countries have these type of programs. Well, I'm not going to go to the whole definition, but it kind of like elevated epidemiology into a way that you can actually be a coordinator in an outbreak response. So you bring the different disciplines together. And DEFINET is the kind of overarching body. They had a really nice presentation to World Epi Congress as well. It was the first time that the discipline of field epidemiology was represented at the conference. You could see the huge number of programs, and they go all from beginning programs to advanced programs, which are 2-year programs. And basically there you have 10 weeks of like training, dealing with case studies, learning how to do surveillance, learning how to do outbreak investigations, and the rest is training on the job. And also in MSF, we're currently looking at maybe developing a program that really focuses on training people in that capacity that want to work more in humanitarian settings, because that's always a little bit different than working for a national public health department. One of the other elements that is really important is, like, we've named these outbreak epidemiologists disease detectives. And part of that is, like, if you want to be a good epidemiologist, you don't just look at your data set. You understand that the data set has limitations and it's a partial representation of reality. So what we also teach people, and it sounds really weird, to talk to other people. So go to meetings, go to the health cluster meetings, speak with colleagues, have a drink with them, because that's where you learn a lot of things. And quite often also for us, like the declaration of a certain disease in a country can be controversial. If it's a notifiable disease, then you will learn much earlier about it from informal networks than you will learn when it's formally declared by WHO as an outbreak. And there might sometimes be weeks between the first case being detected in a hospital, which means you already have many more cases in the community, or at least a few more, up to the point of declaration. And I think especially for an organization as MSF, that often already has a long-term presence in the country, we also need to become better in talking outside our bubble. And also, like, an epidemiologist is kind of working on trying to construct and test hypotheses based on the very limited and fragmented data we have. They understand the limits of the data, but more importantly, they go beyond graphs, figures, and tables. They push forward for the right public health action to be taken based on the data. And this is often also kind of like an controversy, or at least a discussion with scientific colleagues, like, what is our role? Is it to provide the evidence and, we declare the neutrality of science? Or is our role, and I very much believe that as people working in public health, is also to push the evidence towards action and to hold ourselves accountable when things don't move too fast. And I do see that there is a big need for strengthening that element. So none of this is new, because I think after COVID, everybody knows about epidemiological curves. And typically, you have your patient zero, and it's only at one point where a good clinician says, hey, I see something weird here. I haven't tested in a lab. And then you get lab confirmation that you say, okay, let's declare an outbreak and start the intervention. And then obviously, because of all the delays in that, cases tend to increase. And then if you do your job right, as a response community, cases go down. And then typically, we come to the end and we say, okay, let's talk about things like capacity building, lessons learned, policy formation, more academic research that we need to spin off, like randomized controlled trials. But in fact, in reality, it never worked like this. It's like a continuous cycle in many emergencies where you needed evidence at different stages of the outbreak because it curbs due to factors beyond your control. And more, we also realized that, the integration of disciplines is really important. Vertical approaches are useless. We know that they don't work, but it requires a lot of active work to bring all these disciplines together and to kind of come up with a consensus approach of how you move forward. And then it's also imagine when you work in big outbreaks, it's not just the different disciplines, but it's the different disciplines and all these different organizations that are working in the same space that might have different interests also sometimes working in that space. And then you have like, classically dealing, like having worked in the 2014, 2016 Ebola outbreak around delays in data, because I think this was kind of like the first time on a massive outbreak where epidemiologists played a role as real intervention epidemiologists, right? And when you talk about medical data, how does it move within a country? So from districts to the central Ministry of Health, how do they analyze the data? And then the data maybe needs to go from the National Public Health Agency maybe to a group that can do more sophisticated analysis. They do their sophisticated analysis without often having the understanding of how do I tailor my results so people can actually understand them. And then very complex reports are being sent back, first to the National Public Health Agencies, and then it needs to be translated to the response teams. Well, that you go from that costs you a lot of days. And it's kind of the same, I think, for the lab turnover. It's the same for Epidata. So we focused a lot on how can we analyze data on the ground. At the same time, we see there's more possibilities around data. And, this is a paper we wrote a couple of years ago to speak about the epidemiological data that we can collect. What indicators are we collecting? Which one are relevant? Do we have the respect for people that actually, sometimes we ask too much in terms of data collection? Well, actually, these are clinicians treating their patients. So what are the minimum data that we actually need? But then you also need things like denominators. What is the population size? What sources do we consult for that? Because we cannot consistently deploy surveys for everything, right? So is there a National Bureau of Statistics? Can we use their data that might be 5-year-old last census to extrapolate what population growth was in this area? Can we use satellite imagery? And MSF did a lot with that around the Humanitarian OpenStreetMaps project, the MapSwipe project, and others. What other possibilities do we have in terms of an analysis with less user dependency? So the classical image of like someone is having a line list in Excel, makes figures in Excel, and then the next day he needs to do the same thing. What can we do in terms of reproducibility? And of course, there's still a lot of issues, both within our organization as well all the other organizations that are collecting bits and pieces of data around standardization, quality, and continuity. So for us, it brings us a lot to, when it comes to analysis, what is the data that directly contributes to operational decision-making? And what is the nice to have for subsequent spin-off of, more comprehensive analysis that has a bit more of an academic focus. Although I would argue like things like genetics and molecular epidemiology and some outbreaks where we do contact tracing, super relevant. Just not always that realistic with the current capacity that we have in many of the countries where these type of emergencies tend to occur. So also here, like you can clearly say I'm making an advocacy for my group of professionals, obviously. We've worked on many ways of making field epidemiologists a bit of the glue when it comes to medical data, because the way they are trained to look at all these disciplines. And it's not just field epidemiologists, but a field epidemiologist works with the classical academic epidemiologist, works with mathematical modelers, works with data managers who are incredibly important in terms of, designing the systems that collect data and how clean the data arrives at the point of analysis. And we piloted this type of project in DRC during the 2019 Ebola outbreak, where all the organizations were feeding them data to the central integrated analytics hub, which was based in DRC. MSF was part of that as well with our sister OR institutes at the center. And then this data was kind of like fed back to everybody. And then, of course, it kind of fed back into operational decision-making, but also advocacy of how things were curving. And I can tell you the technicalities were not the issue. The agreeing on indicators, the line list, the case report forms, it was a diplomacy between the organizations. And this wasn't an issue on a technical level, because on a technical level, all the EPIs and the microbiologists, we would agree. But it was more on a political level of like, who owns the data? Who will be able to publish on the data? And that created so much mess. But the fact is that it's a reality. I don't think we'll ever be able to resolve that. The only thing we can do is train ourselves to have champions within that community in outbreak response that actually are trained in doing the diplomacy, so these processes are a bit more smooth. Also, the other thing is that success of these examples tends to sell itself. So if you do it well in other places, it will be easier to do it next time in a big outbreak that, for example, WHO, and WHO typically coordinates for the right reasons, many of these big outbreaks as well. So if you look at the cycle from data to action, you go at the point, you start with collection, of course, choice of platforms. Sometimes you have your own data platform. In MSF, it's mostly DHIS2, or when it's acute outbreaks, we use Kobo to make nice line lists. But other organizations might use something else, something that doesn't really talk nicely with other systems. So you need a manual process of a person kind of like, merging the data and making sure that all these incoherent variables make sense. And that's a lot of work. And then comes the step of data cleaning, because a data encoder might not have been trained to the level that he writes all male, female, and gender definitions in small letters. It might be that a lot of variables are missing, but if you want to analyze it in R, you need to code them as missing variables. Otherwise, you get stuck in your analysis. And a lot of these processes become more automated, but it still goes a bit slow, but it's something definitely in MSF we're focusing much more on. And then when you have that, then you need to do the analysis, and then you need to create graphics, right? And the graphics are your tables, your graphs, and it's great because all of us will probably understand it as a scientific community, but it's a medical coordinator that is not an epidemiologist, has not too much affinity with data that has to interpret them. So it's also about, writing really good situational reports that don't have 25 tables in there that are super comprehensive, but just the main takeaway messages that you need to have on top. And then, of course, you have the limitations and such and such. But it's also important that reports are consistent. And that's often the issue when only Excel is used, that you have people that stay for a couple of weeks or a couple of months. The next person comes in, change everything. And in Excel, you just have to make one mistake. Nobody will know about it because nobody will dive into that Excel file. Or someone that changes data, again, nobody will know about it because it's easy as it goes. And that's the thing, right? So for us, it focuses very much on good descriptive tools. Time, place, person. That's the basics of good epidemiology and good informative data that informs your response. Now, and then a lot has focused on predictions and mathematical modeling. And I have opinions about that. Being a modeler at one point in my career as well at LSHTM, I must honestly say the benefits of these type of modeling exercises, for me, the level of attention plus what it contributes to operational benefit, that balance was completely off. Mathematical modeling doesn't really add too much at this point in time in complex outbreak responses in humanitarian settings because the data is often too messy. And the modeling exercise just has to estimate way too much variables compared to what they really are. And we really neglect this.
We have a lot of modelers on the call.
Yeah, that's okay. That's okay. That's okay. I loved always to have these discussions with modelers because I always ask, like, bring me case studies where it has worked. And of course, during COVID, a lot of innovations were made and it helped a lot. But still, the forecasting model is like a 2-week window where it's most reliable. And then after it becomes completely non-reliable because your outbreak, there's too many factors that might change it. During Ebola, a barrier-rich rule that hasn't adhere to what we call IPC practice, infection prevention control practices, might screw your outbreak completely on the other side. A person that travels through a country and has a lot of context screws it. So I think, I'm not saying that modeling is bad, I just think we need to put some limit in terms of where we put the balance. And this is often neglected, the good descriptive epidemiology, while that is actually most important for us.
Yeah, and that's,
So what do we need? A good basis of our work lies in solid descriptive epidemiology, including good background data, these denominators, these maps that I was talking about. A lot is inherent to the ways we collect data, how much we invest in the surveillance and capacity and the development of people within that do the work. And honestly admitting, that's always a limiting factor in where we work. So we don't have the illusion that our data will ever be perfect. It won't be, but if it gets a bit better, we agree a little bit on the ways of how we collect data and we do it systematically, that's already a lot. And then having good tools around data collection, cleaning, data visualization, parameter estimations, pattern estimations, but most of all, consistent reporting on the spot. And why is that relevant? Well, much of it is relevant because of very things that you all know, but I will repeat in any case. It will generate more time for us to do our actual job, which is responding to the outbreak. It will help us identifying the right bottlenecks, treating our patients more appropriately. It will make data more comparable and consistent across time and also across sites. And that's important, right? Because let's say you want to say something about, hey, how are climate variables, because we have good weather data, affecting patterns of infectious disease? Well, if we don't have a line list on infectious disease, it's impossible to say much about it. And I'm not saying that MSF should do all of this, but I could use our medical data and outsource it to a partner institute with a great interest in the subject, and they can utilize the data, especially since we work in a lot of areas where any data is scarce. It will also fortify science over time. It helps us optimizing methodologies. It helps us communicating with stakeholders, increase awareness, and interact with affected communities as well. And importantly, advocate based on solid evidence, because I do think that scientists should move more in the side of advocacy, but on solid data, on solid evidence. So as MSF, we also invested quite a bit in this. One of our first projects was MSF R for Epi. So are there people that use R in the room? Yeah, quite a bit. Okay, yeah. So you might know this project because it was started like in 2018, before it was cool to use R for outbreak analysis. And this was a project that really focused on enhancing SITREPs. So we have outbreak templates and the so-called R markdowns. And basically, when your data flows in, new data every day, you just press a knit button and you get consistent tables, figures, reports out of it. And obviously, this developed then in something else that you guys know, or at least our enthusiasts know it. It's the Epidemiology R Handbook, which was led by Neil Batra and Alex Pina, but MSF massively invested in this as a handbook on how to do analysis. And we have all these nice chapters on how to do time series analysis, regression analysis. Even forecasting is in there for the modelers amongst us, so we didn't neglect that. I hope I didn't step on too many toes here. And we're currently also working on a field epidemiology model that is more about what is the job of a field epidemiologist. So this is very much on methodological analysis and methods around it using R. Just to say that we are sometimes innovating on these areas. The next point is we talk very much about what's happening inside emergencies, but how do we detect events before they become headlines, to which I quickly spoke about. And as you see, we kind of have a global presence in many areas, but often we're very much focused on what is happening within the projects based on data and not sufficiently on, rumors or, something that other organizations are kind of perceiving. While you would say that our presence globally makes us also slightly suited as a global surveillance network. So we are working with WHO in the AOS project, which kind of does early event detection. At the moment, we mostly use that as a platform, but we hope to, in the coming years, to contribute to that. And then you have, of course, classical platforms like ProMed that have detected every public health emergency of international concern pathogens for the first time. But it's still a platform that doesn't get structural funding. Yeah. It's still dependent on donations, which is crazy for many ways, because this was the platform for doctors to kind of write a case report on a suspicious something they've witnessed. And it was quite successful. And it's also a resource that we use quite often. Now, if you look at the landscape, and I took a picture of Paris because I was working at Pasteur, so I was a nice testimony to it. This is the full picture, but then this could be a country or a region that you're working in. But then if you factually look, where do you have a detailed look of things happening? It's the areas where you actually have a presence in medical operations, right? And these might be very varied, because the yellow thing might be MSF. There you might have a UNICEF activity, and there you might have a WHO activity. And there you might have another organization, ICRC, that's running medical operations. And that is basically the picture that we actually have, but then often we over-extrapolate. And we have absolutely no clue what's happening far away. And I think that's also kind of shaping into that message of WHO of what is this collective intelligence, knowing that we all have limited scopes of what we can detect, that we can actually feed it into what platform and get a bit more aware of what is happening, both in terms of trends, but also in terms of event detection. For example, one of the most vulnerable regions, I think, in the world that you don't hear too much of is the Caribbean region. All the islands in there, they often don't have a lot of public health capacity because they're small. They had to deal with a lot of brain drain. I myself am from that region. So how can you help them actually doing event detection more properly? Yeah. They can ask for help. Yeah, exactly. Yeah. That's what I thought. Now, switching to something that speaks more to you, and on which we had some conversation in the morning, technological evolutions on the lab side. So we see these speed bursts of development and heightened attention after each public health emergency of international concern. We see a large stimulation and innovation, but there's often, I think, and I speak just for us, there's a poor uptake of innovations on the operational side. that has to do, the standard and why that is very complex, and I think it requires a lot of more conversation. But we do see that the agenda is largely determined on the high income side of what the priority should be. And then there's tech blockades also by large companies made, like innovations that are being shelved just for the purpose of not being market profitable, even though they are in need. And then we deal with vendor lock systems, which we also discussed this morning, where you have beautiful systems, but as soon when there's an high ask, oh, is that the fire alarm that tripped? I think it is your fire alarm. Yeah. It's a hot subject, this. Yeah. The Monday morning test. Yeah. We have 12 BFL roulette, so maybe we don't want to. Yeah. So when do we need to pack our bags and go outside? Yeah. Just a test. Okay, shouldn't be. Yes. What are they tasting? I love tasting. Yes. No, how do you think? I don't know. Theory, we should have played. Stop. Oh, no. I'll stop in this one. Safe here, not the rest of the room. Okay, there was some good fire protocol adherence. I think. We all know what to do next time.
Yeah. Sorry for the people online. We had a little kind of a siren, but they say that was nothing.
It stopped in this room, so I think, yeah, let's continue maybe. And stopped in the outside as well. Great. So yeah, especially like when I started the chapter, of course, on laboratory, that's when the fire alarm went off. So indeed, aside from the questions that you often have around labs, it's very much about the choice of technologies and how vendor-locked technologies are. And I think especially for us as an organization that wants to treat patients most appropriate, this is a big, I think, bottleneck in terms of why we haven't really managed to innovate on the diagnostics front. It's a complex place. So that's also why we're happy to be here and have these conversations with all of you. why do we invest? I feel like, should I explain it to you? But why do we invest as an organization? Well, the rationale of investing in advanced diagnostic for us, it's a bit more obvious because much of the discussion is often around AMR and ABR, but it's more wider. It starts with what is our question if we're trying to answer? And the two questions are obviously like, how can we better diagnose and treat patients, which is a very clinical focused questions, but then also to add information on the public health context, right? Genomic surveillance when it comes to resistance, trends that are happening, again, in many areas where nobody else has the capacity to really do that work, or even collect the samples that are needed to do so. And of course, for us, it feeds a lot into operational research. And the question too, what tool can best help answer this question? And it's not just about a tool, it's also very much about the partner that helps with many of these things. What can we do ourselves? And of course, then the induced realism around context. Many of the contexts we work in are tremendously complex for many reasons. You will never be able to, have a lab that really has, for example, in the classical molecular diagnostics, a clean part of the lab and the mixture part of the extraction part of the lab. That's not something we would be able to utilize. Often it's the confinement next to the health facility, which is one chamber, where we kind of have to do everything. So that's also where we look very much in not just into the tool for analysis, but also the way we collect samples, the way we store samples, which is really important and also has a lot to do, of course, with the costs. So indeed, the question around sample transport, right? What is the quality, the type of sample, the transport to the point of sample analysis, questions around, how long does it remain a biohazard? How much can we deactivate samples? What about cold chain, which might be needed for, some targets? And of course, the question, are we allowed to transport samples within the country, but especially across the borders, which is tremendously complex in many of the contexts that we work in. And this is just like an example of like a study I participated in a couple of years that looked at malaria serology, where we really went in depth on what happens when you put a sample on a dried blood spot, both in conservation, both on different storage conditions, as well as like, can you still do a quantitative estimate, or will be, certain targets, either cells or genomic material, be centered around certain pieces of where you physically see the blood spot? Same question went from serology, because we had questions here around better targeted interventions based on molecular prevalence as well as serological historical data. And in this example, we used a very basic way of sample extraction, which could be considered high throughput. That's not like in the fancy type of high throughput, but it was a saphonin type of extraction. So basically, it gave us serological material, and from the same file, we could do, we had DNA as a target, but miraculously, also some mRNA targets were still able to be derived from that, depending on what the question you have and how heavy it is. Also, these samples, after extraction, stored really well. So there were some groups that did some MSP2 subsequent analysis to look at the genetic diversity amongst parasites as one of the targets, to look at migration patterns and how that influenced malaria prevalence. And also it kind of was like a bit of more almost direct sample processing and application, because a dried blood spot is not controversial. You can pack them in high volumes, you can put them in a suitcase, and you easily have 20,000 samples in your suitcase. But yeah, it is a bit more cumbersome to then get quality material out of it, right? And that is one of the issues, obviously. And in this case, we really looked at an area of 5 to 20 kilometers and kind of determined what the high intensity areas were, because this allows you to better target your interventions, which is then more cost effective. And fact is that many of these patterns, they don't really change over time, because they're very much associated to water bodies, altitude. And so you can use that as a proxy now to also estimate where you should be prioritizing interventions when you do them in the community. Another example done by colleagues in the team and others was really the implementation of a rapid diagnostic test, in this case of Lassa, where we got not the results we wanted, but the results that were needed to see if this is something we could use in areas where Lassa is a bit more prevalent. So just in short, Lassa is a viral hemorrhagic fever with a few options for diagnosis and treatment, especially in our areas of work, the burden. Well, you can see the statistics right here. But yes, it is an issue, even though the case fatality rate is probably much lower in reality, simply because of the denominator. We don't go in communities and do large surveys. Problem throughout West Africa, with some variation in lineages. Well, transmission patterns, most common mouse you can find in Africa that transmitted through vertical transmission and horizontal. Community spillover, that's about 80% of the infections that we see. And then, of course, healthcare facilities where you have human-to-human transmission because of us not knowing it is Lassa, and patients not being isolated properly, and clinicians not wearing the right PPE. Now, okay, there we are. So the primary objective of this study was really to estimate the real-life sensitivity and specificity of a rapid diagnostic test that could be used bedside. There's different ways of implementing that, and I'm not going to bother you in too much detail. If you're interested in it, you can read the paper. But it was really to kind of look at, okay, we have the manufacturer specifications in terms of sensitivity, specificity, but we all know the way we collect samples, the way that samples are processed, determines very much, not so much the specificity, but mostly the sensitivity of the diagnostic tool. And to implement a diagnostic tool compared to your golden standard, it needs to have a certain sensitivity threshold. Ideally everything above 90, or at least better than your golden standard, is kind of like an important benchmark. And then the secondary objective is really look at the ease of use for our end users. And I think that is an important part of the work we're trying to do as well. So the practical implementation and performance versus the manufacturer specification. Now, if you look at the progression of symptomatic phase of Lassa fever, you see at the beginning mostly fever, extreme fatigue, and general malaise, which is not really specific in terms of a case definition, right? This could be anything. And then, in the vast majority of cases, headaches, sore throats, diarrhea, nausea, vomiting, joint pain, abdominal pain, still not super specific, as in, what would lead to the decision in the health facility saying, hey, we have a case, we now need to take preventive measures, doing more case investigations. None of this really does that. And if you look then at the latter stage, a more severe case, of course, facial edema, signs, that is the alert trigger, right? That is kind of what distinguishes the symptoms from all the rest. Now, if you look at the dynamics of the immune response, so what can we detect by means of diagnostic tools? You see that the molecular presence is relatively short, detectable presence. And then you see these, the responses of IgM obviously pops up a bit earlier, but you can see a bit earlier, not much earlier. And IgG is, of course, the more long-lasting circulating antibody as expected. So PCR, short viremia, is clearly a challenge for diagnostic, and also antibody detection. Is maybe a bit too late into the. So on top of that, a blood sample is not easy to collect, as in it has some risk of exposure. It's not cheap. Sometimes it needs to be centralized in tertiary healthcare structure or national laboratory, which means that results will take anywhere between 4 and 48 hours to reach the end user. That's not good enough, clearly. So there was an urgent need for a point-of-care test, similar to what we ideally hope, the malaria test. And as you know, I think you guys all know the reassured criteria. That's kind of like the reassured criteria formulated by expert panels in WHO. The ideal diagnostic has real-time connectivity. It should be ease of specimen collection, it should be affordable, it should be highly sensitive and specific, user-friendly, rapid and robust, equipment-free or very simple, and deliverable to end users. It's kind of the utopia of diagnostics. So like the goal we're trying to strive to. But especially in our context, incredibly important, of course, some of these elements. Now, I immediately jump to the results because I don't want to talk 45 minutes about this. If you look at the different methods we tested, right? So bedside taking sample, but immediately applying the sample onto the rapid diagnostic test at 15 minutes, at 25 minutes. Then we had a laboratory where the blood sample was pinned down and you used the plasma fraction of it at 15 minutes and also at 25 minutes. Well, this is the sensitivity you get down with, right? So it's a sensitivity of 4.1 up to 50%. Conclusion, not good enough despite manufacturer specifications being quite high, and still the specificity is still above 90%. Now, the issue with this is this was kind of like the only commercially available RDT. There's nothing else aside from more sophisticated laboratory methods. So for us, it was in our interest and the community's interest that this could have worked, but there was also a large discrepancy between the manufacturer specification and then how it's in real life implemented. And this story is not exclusive, right? So this is why we quite often sit on the implementation, because determining sensitivity and specificity in a well-determined panel of laboratory specimens is very different from real life. And I think that is an important part that we all need to realize as well. Now, then there are all these beautiful things that we see passing by all the time, right? So this is an example of a mobile phone with a microscope installation. The solution would be brilliant for malaria, right? Where RDTs, which have a limited sensitivity but good specificity, or microscopes, which are still fastly being used, have a lot of user enhanced sensitivity. So it depends very much on the user of like how high sensitive the microscope. But your mobile phone is a super powerful computer. If you have something that can, for example, an antibody with a fluorochrome attached to a malaria parasite, you can get a quantitative estimate, you can get it super sensitive, and your phone can analyze it, and you're done. Sounds super brilliant, I think, on paper, because it's also easy to implement. So we see these papers arising here and there, but then it's never being taken up to the large level of implementation, because I feel like there's always this commercial border where you kind of like need to innovate and you have a minimum viable product, and then to use it and upscale it, that's where the complexity lies. But I can tell you, these innovations are still highly relevant in many of the cases, and especially with a technology that is super universal, right? You have an antibody that binds to a cell or binds to a pathogen or binds to an antibody with a fluorochrome attached to it. You can use this for everything almost. And for us, it's quite often just good enough to know, does a patient have something or not? But yeah, if you do it really well and you do it nicely and standardized, you can even give a quantitative estimate to it, which is also good for disease progression estimates and successfulness of treatments. Where did they go? I don't know. But I would very much like to find them, right? At the same time, like the mini on, like especially post the Western Ebola outbreak became quite well in the picture, but costs were really high. You still bioinformatic pipelines were at that time not really well established, so you need quite some expertise staff to help implement these solutions. We're now starting really small pilot projects, but I hope that with different technology platforms or the same technology platforms, we can really take a critical look of like what technologies are suited to humanitarian context for implementing these type of tools better. And this includes, but it's not limited to classical molecular tools. So a lot of it, what we do is still culturing, REP type of work, but also we spoke very briefly about the Luminex and the multi-target type of assays, where I've been working with Jean-Claude in the Cebu in Pasteur, where they do a lot of customization of beads. They're now looking at like, you know, how can they push a little bit these innovations to be more suitable to be implemented in not so sophisticated settings, but it's also something that I know that you guys have a keen interest in and that we could further on discuss, so how to make them field-proof, to say so. So we are doing more homework on this, strong rationalization of what we need and what we should be looking at, but then we need partners such as yourself to get us better understand like what is out there in terms of technologies, what can be tested, what can be piloted, what can be validated, to kind of push a little bit these innovations further. For us, it's important to have a strong rationale, right? Because we also have to convince our colleagues that these are good investment areas, important investment areas, despite the fact that in the organization, we kind of all agree that diagnostic innovation is important. But the landscape is vast and it's endless, so we need to be realistic on priorities as well. So that's why we're looking for strong partnerships, not just strong partnerships that can provide a technical know-how, but also have the contextual understanding of where we do this type of work. And that we want to partner closer to organizations that are closer to where we have the majority of our operations for all the right reasons, including building national capacity at the same time and a capacity within the organization. So, you know, we are very willing to pilot and resource some projects on this diagnostic innovation. And that is, yeah, by necessity, really important to us. I just briefly wanted to discuss something I discussed at the conference last week as well, is science, uncertainty, and reality. And I think these are a few important elements when it comes to reacting on big outbreaks. So when we are acting in the uncertainty of a new disease or a known disease, but we just don't understand how they transmit or what the scope of it is, we also have questions with disease X, what are routes of transmission? Is the observed scope the real scope? Or is it just like, because there's now a spotlight on it, everybody gets really hyped about it? Should we intervene early? Or what indicators do you use to steer a response? Hospital admissions, IC admissions, like, yeah, tell us, and we'll do it. Do we apply a no regret policy, as in we find it severe enough at an early stage to go all out? And who sits at the table of decision making? And this I see very much often as a difference between the classical academic approach versus the operational approach, is that this is what people often see as the reliable evidence, the golden standard in evidence. And this is kind of like what we can do in terms of the data that we have and the timeliness of all of it. And this is actually what you can do like in the peak of an outbreak, and all the more sophisticated things you kind of do at the end. And I think COVID was a really good example of this discordance between what I say reality, uncertainty, and people accepting observational evidence for the use of certain interventions, like masks were for me and I hope for many of you working in the lab, kind of the more ambiguous discussions where people said, no, we shouldn't be using masks, even though we do use them sometimes in the laboratory for preventing aerosol transmission from centrifuge procedures and such. And we do that for good reasons and proven reasons. And I'm not sure if I have audio, but if I don't, that's not an issue. Let's see. Wait, I should unmute probably, isn't it? What happened?
Yeah, sorry for the people online, but it was impossible to play in both places. But we send you the link of the video.
Yeah. Okay. So the reason why I showed you this is because we always want certainty when we start acting. But in reality, the more you wait to achieve that certainty, the more things will escalate. And we see that in every outbreak. And after every outbreak, we have huge evaluation reports and we tend to repeat the same mistakes. And I think quite often it's also because we listen to academic evidence and scientific evidence, but we don't listen that much to expertise and people that have run the show in many times. And I see that quite often being repeated, but COVID was clearly are good examples. So be fast, have no regrets. You have to deal with what I showed, that bottom part of the pyramid when it comes to evidence. And yeah, sometimes you need to work on that and move on that. And when you get new insights, that's when you get new insights. And then you acknowledge that you maybe have to change your course of direction a little bit. Public health is also more than medical science and data, right? So the clearest example was the Western Africa Ebola outbreak in 2014, 2016. There's an emergency unfolding. Organizations, including MSF, are ringing the alarm bell, and it still takes months for the international community to start working on it. And 11,300 people died just of Ebola. It's probably an underestimate. Many more died of malaria because, yeah, we forgot about malaria, and there's a lot of similar systems, but also the fragile health systems were already overburdened. And a large part of the Western countries only engaged when escalation was full. Nobody cared for a long time. They started caring when expats coming back infected. And instead of like properly financing the response, and the Europeans were now, for example, talking about having more BSL-4 labs as nice prestige projects, or having medical evacuation planes, like some of the German colleagues had that actually never flew, but it's still there and it's a nice to have thing. And I think this is really important to kind of highlight that sometimes, what we do and what should be done is quite different. And there was an Ebola vaccine, right? It was just shelved for decades somewhere because there was no economical benefit for it. And even nowadays, when the vaccines have become commercialized, the stockpiles are still very small. And every time when there's an outbreak, it takes time for the stockpiles to move from left to right. A nice book to read is The Politics of Fear, written by MSF colleague Michiel Hofman, around the reconstruction and why it took such a long time for things to move and why that is an issue. Linking back to some of my first slides about the politics during outbreaks that we should not neglect and we should actively engage in. Now, if you look at the public health emergency of international concern, that's a nice list. And then in 2022, 2023, we had Mpox, and now we have another Mpox outbreak happening that is escalating. And you see the same patterns being repeated, where everybody hoped that the question around equity in vaccines would have been resolved with the biggest global infectious disease crisis. Nothing has been resolved in many ways. And then I've attended a lot of these high-level meetings around equity, and I become very cynical at one point about it. And it's also where I believe that academics should engage more. So it's not just about the fact that we engage in the technological innovation, but also how we dare to push the narrative and be critical about how we set up models of innovation and who has access to these type of innovations. Last part, the partnerships in research. So for us, it's quite clear why we want to engage in research. So it can be internally questioned where research exactly has a place, but it's true that we have many examples of research in MSF that were done because nobody else wanted to do them, and they led to really positive global changes. And I think that's all for us a role to complete, but sometimes it's challenged a bit more. And the questions around operational research, so the question, what does it add? In principle, I always think it should be quite simple. How can we do our job better? What are the coming challenges? How can we better anticipate? And how can we strengthen ourselves as an organization or a response community to assist populations that are in need, including policies and guidelines, including medical guidelines. And the other part is like, how can we document stories of affected people? For me, that's another thing that's really important. So in the end, it summarizes the gathering better methods, tools, and data for operational decision making. And the spin of that can be research. And of course, a big part is about equity in research, like who conducts the research, who is the one telling the story, who is the one documenting the story, who is most prominent on the publication. And I think in MSF, we really try to become much better in that. Like, for example, we have an open access policy, which means that more than 95% of our publications by default goes into open access journals. The 5% or maybe even less, we're trying to change that as well. It also has to do with the fact that we're not looking for tokenistic partnerships. You have someone from MOH on the paper, not because they've actually contributed a lot to the research, but because it's a thing you had to do to actually do the research. So the real investment in partnerships are really important, both inside our house, but also within our operations, including national staff. We're really trying to boost the capacity within our national staff as well. and our international staff for that matter. But also how we think about partnerships outside our house. And I think we can all acknowledge that inside our organization, especially, we're not so good yet in building really strong partnerships where we actually should be doing that, because we don't have the capacity quite often to do everything to that same level of detail and comprehension than other partners might be, especially the partners that are closer to our operations. Also aiming for better community and patient participation in all phases of operational research where applicable. And I say where applicable because, yeah, we often get these discussions and, yeah, this is what you should be doing, etc. But then if you look at really well-resourced settings, they're also pretty poor in interacting with communities and with patients. Also, our communities really, do they really want to better interact with us, or they're like, do your job, do a good job, improve our lives, and that's enough for us? And the same goes for communities as well, of course. So we need to be realistic about these aspects as well. And then we have, for the right reasons, quite high ethical medical standards that we designed to do humanitarian research, because we deal with the most vulnerable populations around. And that's also what we expect from our partners. We do, as I said, quite some training on operational research. We have different initiatives on that. We moved from a more classical model, which was called assorted, to a bit more advanced model that also targets like senior medical staff in MSF, because often they have great research ideas, but the problem is finding the time and space to actually do them next to your day-to-day work. So in 2022, we started, or 2023, we started the first training that focuses on research project on climate, environment, and health, the intersection of this, which is easier said than done. But for example, one of the projects is enhancing the way we use our malaria data, doing time series analysis, so that in each context you can better understand when the season is starting, when it's peaking, so you know when to implement your interventions better. And in 2025, together with our pediatric reference across MSF, we're doing a training differently on the pediatric medical gaps. And so we move forward on the thematics that people propose. Aside from that, it's not just about the vertical technical aspects of the matter, but it's also very much about the how to do research. So we co-developed a course with the University of Utrecht in the Netherlands on ethics and equity in research and global health. And this is also aimed more to people that, come for the more, that already do research in their day-to-day, but want to learn more about ethical frameworks, better practices. And we have quite a diverse group of experts in this area that works on this actionable research. So it's really about the outcomes. What does it mean? How can we influence change, both internally but externally? But also talk about different research priorities, which is always a challenge. Do you look by geography, by medical discipline? How do you share those resources? And again, this is where partnerships, I do think, can make a difference, because with effective partnership, you can simply do more. And then very fundamentally, the data is integral to telling stories that need to be told. And that is very much something that we sometimes forget is also our job, because that's kind of like what is in the core principles of MSF. And then quickly an example from Cox's Bazar. You might know about the Rohingya refugee crisis, which you always had refugees coming into Bangladesh, but in 2017, the conflict escalated and about 800,000 people fled into Cox's Bazar, which was a very vulnerable area already. And I started there in 2017 and I came back in 2019, and I was surprised by the limit of publications, despite 129 organizations, national and international, working on health, had been published from that. So I took it together through the health sector to kind of do this exercise on operational research. And in the end, we did manage to publish 7 papers together, including a paper on the largest diphtheria outbreak documented in recent history, which happened within Cox's Bazar, but also how we managed to work together as medical organizations. So we had a very well-functioning cluster mechanism, which is kind of an exemption. But and this had authors from all kinds of organizations: MSF, WHO, UNICEF, IOM, CDC, ICDRB, National Institutes of Health, that were all co-authors on all these papers. So yeah, sharing knowledge is also documenting the story of the crisis and the people. And again, like, it doesn't mean that we have to testify on all this data, but medical data around trauma does feed into accountability mechanisms. And I think it's an important responsibility. Like, you don't have to be outspoken as a medical person, but if you make sure that the medical data arrives where accountability can be held, that's really important, because without that medical data, accountability is an impossibility and speculation gets the overhand. Collaborative models. We spoke a lot about that, but partnerships are essential for all sides, but especially around solving the issues. especially like partnerships that can build more sustainable. And I've just named a few areas. Migration for us is like something that we see definitely on the increase, and it's really complex in terms of models of healthcare delivery. Vertical diseases, so the colleagues of SAMU that discuss like the subjects that are really important to you guys as well, HIV, TB, Hep C, for example, NCDs, but also discussions around research environments. So what about the ethics, the equity about it? How do you make partnerships? We don't discuss these things sufficiently enough. We only discuss technicalities too often. We have different models of attaching scientific people to MSF in terms of exchange, research, master students, PhD candidates, senior staff that sometimes is embedded for the duration of a project to help with analysis or certain phase of a research study. But yes, there are also complexities around funding, the adherence complexity of agreements, not just institutional, but also across the legal lines within different countries that we try to collaborate with it. And often we also saw with some of our academic partners that it was more about getting access to rather than really wanting to contribute. And unfortunately, I've seen it mostly with the more prestigious names, and I tend to move a little bit away from that. So I'm like, yeah, technical expertise is important, but what is more important is that we share a common value base of collaboration. We're also not super easy. That's I think we would be the first to say that we are sometimes also our worst enemy when it comes to doing operational research, because operational research requires a longer term commitment to fulfill from A to Z, so all the way to policy and practice change. And sometimes our thought cycle is shorter in operations, from a year to year kind of thing. So we need to acknowledge that it's really important that we spend more time in exchange on how to build partnerships. So not just the technicalities, as I keep on saying, but how to build new models of partnerships, because they're greatly needed at the moment. Also, lack of equity, big subject that we also discussed this morning. The MSF Access campaign does a lot of work on this. During COVID, we had the TRIPS waiver, which was heavily supported from South Africa. And this is an area where I didn't find biomedical scientists engaging sufficiently, to my disappointment. And I would say, like, if there's a huge scientific disagreement, then you would see more heterogeneity in the pattern of how people voted, right? Well, clearly you didn't. Like, it was the center of European that voted against, and then everybody that was kind of in need voting in favor. So for me, this was more about, the politics, the economy behind it. And what was really missing here is strong biomedical voices. And I think as a community, we also need to be thinking how we want to engage in these arenas more jointly. Nice read by Amy Maxman, published in 2022. A lot of African countries are like talking about radical change. So like, like India did, let's ignore all those patents because we need life-saving medicines, and we need to. And I do think that we need a new momentum of radical ideas in models of delivery. And I think the time is now, because, COVID, Mpox, and it showed nothing will change. And if we're waiting for that, then a lot more people will be dying than is needed. And I think this is a nice article by Ed Young, Pulitzer Prize-winning journalist from The Atlantic. And he wrote a really nice article how public health professionals kind of retracted during COVID from these political discussions. And I was saying, like, the political arena is more tense than ever. Also with disinformation, the large number of threat scientists get. But we can't retract from this arena. We need to be proactively engaging in that. As different organizations from different angles. Really nice analysis that links back to the HIV/AIDS epidemic in the 1890s in the US, and how important the voice of medical people was in this conversation. So concluding, we need science more than ever, but we need kind science that is able to descend down from where the context is, to listen, to understand people, the situation, the needs, and to co-produce solutions. More value-based science that is not too worried about taking, activism, and takes a bit of pride in that as well, that we can actually influence policy change in practice. And we need to discuss with each other, like, how we can do that in the best way possible that doesn't allow us to burn out. But yeah, form a joint voice and how to push for that change. We also need to ensure that we keep young scientists motivated. The landscape has changed. It's not just about how science has changed, but also the political situation for young people, like social securities, getting a house. People are incredibly worried about climate change and what it will bring. And I do think for more senior scientists, we need to really uptake that responsibility in creating a nurturing environment in academia to deal with these types of things. Because yes, we are getting more crises. And how do we work together? Should we as scientists not agree on what we value as scientists in science, which is not just the metric of publications, impact factor, H indexes? I don't believe that any of us went into science because of this. So shouldn't we not take ownership much more of what we value in science? So we need to go back to the core values of what science is, and it's more than a body of knowledge. Science that is brave and bold and can challenge the status quo in a safe way. Because for us, it's also rethinking about how we can do operational research in humanitarian context, because the problems in global health, the current one and the rapidly approaching ones, are very real. It's not a story of tomorrow. It's not about the technical solutions, very much how we got there, who participates, who can use these solutions. It's all about reasonable and not always complex questions. I think sometimes we tend to overcomplicate situations much more than they really are, especially when it comes to vaccine equity, for example. And I do feel that we more widely need to adopt an operations-oriented approach. So how does it benefit patients? How does it benefit communities? We can formulate questions here and try to bring them on the ground, but often you see that the other way around, local solutions are not finding their uptake that easily. And emergencies often take longer, so developing agendas should actually become easier, right? And there's actually no argument to work on longitudinal agendas of operational research. It makes it much easier to apply for funds. It makes it much easier to develop a vision within our houses and like how we want to occupy it, what we need in terms of HR and such. And also in MSF, I don't think we're particularly good in that, but our average primary healthcare project lasts about 6.5 years. And still we only reason from year to year. So really concluding now, we need a new generation of rebels because the public health issues around the globe are very real. And the question is really like, focusing on the fact that making partnerships and inducing a change doesn't come free and by itself. It's really hard work. It isn't just a side job or something you do on top of that. But the issue, of course, you're not accredited for that as scientists. And I could clearly see that with all the R stuff that we did. I think we could see in the metrics that so many people globally were using it, and we got so many emails of support, but our academic institutions really didn't care about it because it didn't result in a publication. And I think that's a really important part is like, how do we enable and support each other in this factor? Because the fact is the need is there. So yes, we do need a new and current generation of global health activists that use science as their fundament and heart as their drive. Famous Chinese proverb, better to light a candle than to stare in the darkness. And I think for us as in the humanitarian work, I think it's a very important thing that we often, maybe we need to print out a few posters and hang them in the office as well, because sometimes it does look a bit too grim, but there's great people across every institution that we can collaborate with. So thank you for having me, or having us actually.
Yeah, thank you so much. Yeah. And yeah, so open for questions and discussions. Normally we have lots of questions, and I think that was quite exciting presentation. So we're gonna open for that if you don't mind. Yeah.
Okay, thank you, and nice presentation. So my question is just to know, from all the presentation, I got that data is really critical. So from your background, is it something that is usually challenging when you go to a new country and you need access to those data for like a new outbreak? Is it something that is usually challenging, or is very simple to have access to this data? And when it's challenging, how do you manage that? Thank you.
Yeah, it's a good question, and I think my favorite answer is it depends, right? I do think like in some times when outbreaks tend to be a bit more political neutral than conflicts, for example. So you see it's easier to speak to the data, but we know of countless cholera outbreaks that are not labeled as cholera because cholera is a notifiable disease. It's called acute watery diarrhea. But yeah, I mean, amongst the response organizations, you still speak about it. Conflict is a bit more difficult because when you do medical witnessing, there's a real accountability aspect to it. Like what is the type of trauma you observe for patients coming in? And you see that there, I think the balance of discussions of are we doing more the witnessing or are we maintaining to our operational space? Yeah, these discussions tend to be a bit more strong. in that sense. But it's true that, like I said, like medical aid or medical work in general across the countries is becoming more politicalized. So we need to find mechanisms to deal with that. And one of the mechanisms is sometimes you can do your medical job and regain your operational space, but you can maybe outsource the data through other pathways. Academic partners, other NGOs that are specialized in that without ever naming yourself. These are mechanisms you have to utilize. So the smart diplomatic part of the work and how to gain access, maintain access are really important subjects for humanitarian medical organizations all over.
Well, thank you so much for the amazing presentation, truly inspiring work. So my question is around, so I understand that the organization is distributed across multiple continents, and let's talk, in this case, only across Africa, and you need to respond fast. So how does the organizational structure facilitate agility or agile response?
Yeah, also a good question. So part of it is the way we're funded. So like many other response organizations have earmarked funding and they have a small emergency buffer that they can use very quickly when something acute happens. But I think our way of funding allows us, especially in big emergencies, to respond very quickly. And then, of course, it is true that we have acute emergency projects that arise from nothing. But typically in many of the countries, we already have a presence. Right, the Western African Ebola outbreak, we already had a presence in a lot of West Africa, which allowed us to ring that alarm bell, but then also upscale the operation so they could tailor it to the response. And that's the case of many contexts. But fact is, you cannot have a maximized operational presence at all times everywhere, right? So we're really trying to continuously evaluate where the gaps are, which is not an easy job. I mean, none of what I'm saying is as streamlined as it comes out of my mouth. It's much more chaotic in reality.
Okay, thank you very much. I was kind of interested in the operation research aspect and the sustainability and prioritization within the program implementation. So I really love how these program projects are kind of prioritizing the operational research, but the problem is sustainability within the program, the operation research within the program. So I don't know how can it lead to a success story after this operational research to this, because most of the information that I've had with regards to the operational research is that it's a good idea now. Once we start working on it, implementing it, now the funding ends. Priority of the program wasn't on the operational research. So how will we find this one? Let's say even before we have this kind of collaborations now within the organization, how can it be sustainable? And also politics within the organization can also be like, well, this is not our priority, irrespective of having this operational research here. So where's the way forward? Thanks.
So this is a very real challenge, why we often struggle with getting ideas of operational research really well implemented, but then also well resourced, I think, over time. Because operational research is not something you can dump on an existing team that is dealing with day-to-day medical operations. You need dedicated HR to it. You need dedicated expertise to it. All of these elements are really important. And then the second part to it is one of the things that, for example, we did in our corner of the house is implement an operational research process. So that means that the process doesn't just look at the quality of research, how well it's resourced, if it meets quality standards in terms of methodology. It also kind of makes sure that the buy-in is there on all levels. Project level, HQ level, technical reference level. And it's not a guarantee that things will go better, but having everybody sign the tick box off before you start the research, we will implement this research, we will do it, and we will kind of work towards it to the end, is already a good beginning. While in the past it was a bit more ad hoc, and ad hoc led a little bit to the danger of lack of continuity when you would have, for example, a new coordinator in a project that doesn't deem it a priority, and they have to financially scale back in the next year. Well, the first thing, for all the right reasons, that tends to drop off is operational research.
Yeah. So we have one thing that we didn't discuss, but I can see Rudia has her hands on. Rudia, you are welcome to unmute yourself. Yeah. Is that our organization, at least CERI, we are mostly data driven. Yeah, we like the lab. Yeah, but that's a small percentage of our work. Yeah, because we think that the value is on the data and would be good to engage there. But Julia, yeah, you can ask your question. Yeah.
Thank you, Tulio, and thank you very much for. Sorry, I'm getting some echo from.
Yeah, just a second. Try again.
Yeah. Okay, I think it's better. Thank you so much for this very inspiring presentation. So I'm the head of the data science unit at CERI. I'm so sorry for not being there in person today. There are multiple points in your presentation that I thought very pertinent to our research as well, and would like to get some perspective from you. One of them was the association between human migration and climate change, which we are also very interested in. And we are trying to use, for instance, satellite imagery to see how we could infer large-scale population movements following, for example, climate migrations. So I'd just like to hear from you what you've been seeing around this aspect in your work. And also maybe importantly, how do we deal with not using kind of blaming language to climate migrant populations once we see patterns emerging, because surely these populations are the victims, but how do we communicate and advocate for data-driven action without blaming these migrant populations?
Oh, these are really good and complex questions as well. So like migration is one of the portfolios that I deal a lot with. Like one part is, for example, Cox's Bazar, and the other part is European migration, which kind of tends to, start from the part of Northern Africa, where there's all these migration pacts being made by the EU and many countries to what I call is the artificial extension of the European borders. So you stop people from ever coming in, and you do it by consciously, I would almost say, maybe that is blaming language, by breaking every form of humanitarian law, maritime law, and much more of this. And this is under a lot of pressure because these are agreements we have as a global community around maritime law for which we witness they are being broken based on testimonies from what we see ourselves as well as what we hear from our patients. I think when in 2015, 2016, when you had the big migration influx following the war in Syria, for example, into Europe, as public health professionals, everybody was like, hey, we need to see what type of vaccine gaps populations might have or what type of diseases they carry with them without it becoming a political playfield of like migrants are bringing disease into our country. And it was incredibly complex. But what we saw actually, the frequency of infectious disease was actually extremely low. So actually the message that was given then is like, no, they're not bringing new scary diseases into the population. And I think on one part, yeah, you need to speak in the medical data, and it could have been different if they came from another region of the world, who knows. But I think transparency within the public health community and first discussing what you see in terms of data and then thinking with, for example, social scientists, or in our case, our health promoters, on like, how can we tailor these messages so that they are doing their purpose, which means we need to help people, but at the same time cannot be easily picked up for political controversy within our sphere of influence, which we have to recognize we have no control over what populist politicians will do with the facts that we bring forward. As you guys, for example, have seen with new variants arising in South Africa and travel restrictions, is something we need to do better. How do we package our messages? What are the key points we want to bring forward? The ones that are in the media quite often, of public health professionals, I feel that some of us need to be trained much more into that. Because, yeah, the facts that we give forward can lead their own lives if we don't package them in the right way. And then I would love to talk more with you actually around the intersect of like advanced analysis. So we've worked a lot, especially with our colleagues in Epicenter, but also myself on the relevance of health data. How can we do much more on the intersect of climate? In MSF, climate is a really big subject. Not saying that we are becoming climate change experts by any means, but we, like I said, we witness some changes, but we need expert institutes that indeed can help us with proxy data, identifying trends, as in so that we can tailor and adapt our response better, operational adaptation. as well as occurrences. So like we can collect data on infectious diseases, but we need other people that can collect data on climatological variables and link it up and, see if it corresponds with increases in case data. Still, might not be a causal relationship, but it's good to kind of look into that and become a bit more systematic. I'm not sure if anyone attended the World Epidemiology Congress last week, but there was an excellent talk by a colleague on data around climate change. And it showed, especially for the African continent, there is some data coming from South Africa, but then for other countries, it's kind of like quite devoid. So I think it's also our common responsibility of what can we include in routine surveillance and routine monitoring programs. And it's a discussion we're currently having in MSF as well. So I'd love to chat a little bit more about that with some of our climate colleagues as well.
Thank you. And I'll give you the last question.
Thank you so much for this great presentation. I'm just going to follow up on Hoya's points. We're actually working with trying to include more of the climate data, and it's also like data what we can find online, and that's freely available and accessible. And so we're trying to also include epidata, like occurrence data, and that's also not super accessible. So that's the area I think that we do look for more collaboration so that we can bring more information to the scientists on the ground, especially. But also, so we're doing the best we can with the data that we have at hand now. And how is this viewed? Because I feel like it's not 100% correct and perfect, but it is information that we're still contributing. So we're getting there, but it's still not perfect. So how's that viewed in terms of like scientists on the ground and how useful that's seen?
It almost brings us back to the conversation around the role of mathematical modeling in response. So the question to any form of data collection is, to what purpose are we collecting data, and to what purpose is it going to help us with operational decision making or advocacy for that matter? So I think like here, I'm not sure if it will directly help us with operational decision making and how to change strategies within programs, because when malaria increases, we'll do what we've always done, and that is deploying interventions from the toolbox. But it will definitely help advocate the fact that the impact of climate change is incredibly real and it's happening, and we can support this by metrics. Rather than at the moment where the discussion quite often is, yes, there is a range of diseases by modeling studies that are climate sensitive, but we also know that climate sensitive diseases, like if it gets hotter and drier, doesn't necessarily mean that certain diseases will increase. They might as well decrease for the moment in time. If we see more floods, for example, or more heavy rainfalls, it doesn't necessarily mean that malaria does increase, because if the floods happen at the time where mosquitoes lay the larvae, all the larvae are washed out, and you actually see a steep, slow decline. But again, it's like weather patterns versus climate change, right? So what we see on a day-to-day basis versus the longer-term prospects. So I think in that part, it's very clear that MSF does want to play a role. And the other thing is adaptation. So how can we become better in understanding how trends will develop over time so that we make the right investments where it's needed? So we have 3 pillars. One is operational adaptation. The other one is like reducing our own footprint, because yes, we have a footprint as well, big one maybe. Actually, we have never quantified it, so I'm not sure how big it is. And the last pillar is advocacy. So I think that is an important part, because partners that actually do a lot of advocacy in humanitarian settings are quite limited, and especially with issues of like migration. We know that if a climate or vicinity becomes less friendly to people, then people will migrate. But typically they tend to migrate within their own country, because that's what we do, because traveling across Europe is super expensive, has a lot of risks that come along. But yeah, it's good to kind of get insights into why we see an increase here, what were the causative agents of it happening, and satellite imaging can help with that as well as deriving very strong patterns of weather indicators, right? So we don't need weather stations everywhere. A lot can be derived from satellite imagery. Again, not our expertise, so this is where collaborations can definitely come into play.
Okay, so thank you so much, Amrish. It's great to be here. I think that we share a lot of ideas between the organization. Normally, is one of the first people that I heard to tell us to become more activists. Normally, people tell us the opposite. Yeah, not the opposite, but we take very serious also activism and make sure that the results arrive where it is need to arrive, and it's communicated in the right way, and that sometimes we are very vocal about what's happened with epidemics. That's again and again and again that we are mostly forgotten in Africa, and we are only remember when there is an interest from the global north, and that's one of the main reasons why we invest so much of our time and resources on capacitate the next generation of scientific leaders in Africa, even if they are not here with us. Some people even say that, oh, you are training the competition, and we look and say, no, we are not training the competition. We are making sure that higher level science can happen where it's needed, not the opposite. And if they become a strong competitor, it's even better. It's better. We need more high level science to be done in Africa that have the impact, because that's where we are the ones that know where the problem lies, and learn from the ground.